Hello and welcome to Health Affairs This Week. I am your host, Jeff Byers. Before we get into today's episode on pharmacy benefit managers, I wanted to note Health Affairs released a new issue this week. One of its core themes is pharmaceuticals, with a focus on insulin costs and biosimilars uptake in the U.S. It also has some great papers covering dual eligibles, Medicaid, and more. Check it out in the show notes. Also, on August 19th, we are hosting a virtual event entitled What Do Recent Nursing Home Developments Mean for Residents, Families, and the Future of Long-Term Care? The event is part of our Age-Friendly Health series in partnership with the John A. Hartford Foundation and will highlight the latest developments and policy implications for nursing homes in the wake of the COVID-19 pandemic. And with that, here today to talk about America's favorite middleman pharmacy benefit managers, or PBMs, Stacie Dusetzina is back on the program. Stacie, welcome back.
Thank you. Very excited to be here to talk about PBMs.
So some people might know what PBMs are. Maybe they don't. For just the uninitiated, what, from a baseline, is a pharmacy benefit manager?
Okay, a pharmacy benefits manager you can think of as your negotiator if you are an employer who wants to offer benefits or you're a health plan. They typically serve in a function of developing and setting formularies, deciding what's covered, deciding how accessible a drug is, how expensive it is to a person on the plan, and they are tasked with negotiating prices from drug makers. So basically, we have these large companies that take all of these patients that they represent and they say, okay, I've got millions of covered lives and I want to get the best deal possible on a diabetes treatment. So they work with manufacturers to figure out who's going to give them the best deal so that that drug gets formulary coverage and preferred placement. So if you are thinking about how your health benefits work, you certainly have a PBM involved either in those negotiations, processing claims, or both.
Fantastic. And I should note that you wrote about PBMs for one of the newsletters that you write for the Health Affairs Insider program. So check that out if you are not an insider. And I am reminded there's only a couple of major PBMs. Is that right?
That's right. 3 PBMs control most of the market. And this is one of the key reasons that people are starting to worry more about pharmacy benefits managers overall than maybe we did 10 or 20 years ago. So, back when I got started in this research area, there were a lot of pharmacy benefits managers that often a health plan would go in contract with to negotiate for their benefits. And you could almost think about it like health plans and employers were shopping around for the pharmacy benefits manager that was going to give them the best deal for managing that part of the benefit. Now, pharmacy benefits managers are really 3 major companies. There are more than that, but those 3 control, I think, about 85% of the market or 85% of the patients in the US who are getting drugs. And so that ends up being heavily consolidated. And the other thing that is really interesting and brought out in a recent report that we're going to get to is that they are incredibly integrated into this larger set of healthcare entities. So instead of a health plan going out and bidding out the pharmacy benefit work to different PBMs to get a good deal, those health plans now own pharmacy benefits managers, or they're owned by the same parent company. So you no longer have your health plan separate from your PBM. They typically are owned by the same parent company.
And you alluded to a recent report from the FTC that they published last month on PBMs, which is a big reason why we're talking today. Can you walk us through the purpose of that report?
The FTC has been really interested in the competitiveness and the industry practices related to pharmacy benefits managers. And in fact, Congress has become really interested in doing something about pharmacy benefits managers. It's why you've probably, even if you're not working in the space regularly, have started to hear more about pharmacy benefit managers, is that members of Congress are concerned about their role and, whether they're increasing drug spending, how much they cost the system. So they've asked the FTC to look into these business practices. And this report that came out is actually an interim report associated with the pharmacy benefits manager and work around transparency.
Oh, interesting. And I noticed that this report is a result of a 3-year inquiry. So I don't know how else to say it. Like, is this a big deal? Like, what's the biggest revelation from this report?
So one revelation is that this is an interim report partly because the pharmacy benefits managers appear not to be complying with the request of the FTC to provide documentation about the financial relationships that they have. So FTC sent a laundry list request to PBMs. They're like, we need all of this information about your business practices. And despite how concentrated and consolidated this market is, some of them have decided not to reply. And even in the report, when they talk about, that they haven't gotten the information that they requested 2 years ago from the PBMs, they emphasize that they're ready to take them to court if they don't get the information. So I think this is an effort by FTC to kind of say, here's what we've learned so far, but also to highlight the fact that there is not really a complete compliance with their request for information.
So the immediate thing of like threatening to go to court, based on what you know or that you can share with us, is that a threat that these companies care about?
Yeah, I don't know the answer to this. I mean, I guess I always assumed that if the FTC tells you you have to do something, that you would do it.
Yeah, one would hope, right?
Yeah, it feels like, a group with authority that you don't want to have, not on your side as a business or an organization. So it is a little bit surprising both how reluctant they are to turn over information that has been ordered, but also the fact that FTC is like, clearly getting kind of annoyed by the fact that they don't have the information that they need. And the information that they do have does not paint the best picture for PBM practices and, what we can expect going forward.
Yeah. So would you say this interim report is an equivalent of a per my last email request?
Yeah, I think this is like, FYI, the FTC has been asked to dig into this opaque system because the goal here is to really try to provide some transparency and understanding of the business relationships that no one really knows about, so that we could think about what regulation might need to look like. Are these entities operating in the best interest of the consumers who are using them? Are they overpaid? Is the government getting ripped off? There are important questions FTC is, needing to look into, and they've been requested to look into it. So I would imagine it's a little bit of we're trying to do our jobs, but we are being blocked by the entities that, Congress is, thinking about ways to regulate. So yeah, per my last email.
Yeah. You mentioned that PBMs are pretty opaque, and you did talk about does this interim report help with this opaqueness at all?
In a way it does, but what you'd kind of hope is that they're like, oh, it just works like, this kind of easy pathway, this clear, set of entities, and here's how they operate together. In fact, I think it actually highlights some things that maybe we didn't fully appreciate as far as how complicated the system was. So one of the, I think, maybe not surprising if you've been, really deeply steeped into the PBM space for a while, but a newer entity that has emerged is what is called a rebate aggregator, or a PBM GPO, group purchasing organization. Okay, so when you read the details of this, it sounds super shady. It's bad. It's like, okay, so we have these 3 PBMs that have most of the market. They have spun out these additional entities, which they claim is to further consolidate their negotiating power. But it's like, it's almost a one-to-one match between PBM and this aggregator. So it's not like they have more covered lives to negotiate for. So that argument about it's to consolidate the bargaining power seems to make no sense. I mean, maybe I'm missing something. They're also, I think 2 out of 3 are overseas companies. And there is a concern rightly so, that these entities just exist to take money out of the system and be able to then say to clients, oh, we're giving you all of the money we negotiated. It's just like this upfront fee thing that gets carved out where it's like it's adding to the cost of doing business. It's increasing profits for these entities. And it's allowing you to just say to everybody else, oh, okay, well, we're giving you all the rebates back. What are you complaining about? But we just call these other fees different. We call that something else. and then you don't worry about it. So I think when I was reading this, FTC does a nice job of describing also that group purchasing organizations have a special carve out around anti-kickback statute that seems like a clever way to be able to avoid some legal maneuvering that might harm PBM profits. And these entities have only popped up in the last couple of years. So good news that we know about these. The bad news is that they exist, and they appear to exist just to create more profits for companies that own PBMs, and not necessarily to help lower spending on drugs.
I mean, growth at all costs is what I've been told.
And one more thing that I think is just, it's not necessarily to the transparency, maybe a little bit. It highlights some really interesting, concerning behavior around the vertical integration of pharmacy benefits managers into these very large kind of entities. So they have a graphic in the interim report that shows the consolidation of pharmacies and PBMs and health plans, where it's like they're all owned by the same parent company in many cases. And they show some examples of generic drugs, generic specialty drugs, where the amount that's getting paid to affiliated pharmacies is really, really high relative to how much the pharmacy would be purchasing that same drug for. And there's a really good quote, and I'm not going to get it exactly right, but there's a document where an executive is talking about the fact that, you can get this particular drug for $100 at one pharmacy, thousands of dollars at a preferred pharmacy, and then, even more from the mail order. And they're like, we push the mail order, but it's 200 times as much to get the drug through mail order, which makes the optics look bad. And it's like, yeah, that does look pretty bad.
Right on. So we did talk about Is there anything else on consolidation that you want to hit upon?
I think for the consolidation piece, this has come up. MedPAC has done a little bit of digging into this space for the Medicare Part D plans before around the relationships between pharmacy benefits managers and their preferred pharmacies versus not preferred pharmacies, and potential for overpaying your own pharmacy. And we also know from a lot of the independent pharmacy business, we hear a lot that those pharmacies tend to get underpaid, or that they might actually have more money taken back after the sale. So pharmacy benefits managers often have these clauses in their contracts that they're called clawbacks. That's the term that gets used by pharmacies, where it's like you might get paid a certain amount up front, but then you have to pay some of that money back. So I think that, when you start to see this integration and consolidation of these businesses, where it's like the PBM owns the pharmacy, you end up in a situation where it just feels a little bit like the deck is stacked against independent pharmacists especially, but even chain pharmacies that are outside of that particular, company's own set of chain pharmacies. So that ends up being a little bit concerning, that you want to know that people can go to the pharmacy that's convenient for them to get their drug and not be price gouged. So the example for that generic drug, which I do think is one of the more extreme outlier cases, but is a good example of, you literally could pay, $100 or multiple thousands of dollars for the same drug. And that has big implications for the person filling that drug if they don't know that price difference for them.
Yeah, and the deck is stacked against independent. Doesn't seem to be regulated to just the independent pharmacy. If you chat to any budding songwriter in Nashville, I'm sure you can get similar topic. So we have a couple more questions left as we are continuing our conversation. Based on this report, how are PBMs affecting drug prices?
I think that it's always a complicated answer to that question. So not just based on this report, but in general, I think it is important to recognize that, a world without pharmacy benefits managers, but maintaining everything else like it is in our current system, we know would likely mean we have to pay more for drugs overall. I think there is a really important and pretty clear kind of signaling from this report that pharmacy benefits managers are probably overpaid. They're probably getting paid in ways that we aren't even really aware of because we don't understand how their business works precisely. And that they still probably save us money relative to not having them. There are definitely outlier cases. Like one of the things that I think is so compelling about a report like this is you incorporate these patient kind of like anecdotal like information about like what exactly each person is experiencing trying to work through their PBM. And it sounds horrible, but that's not going to be the experience of every person and every drug. So you've got some outlier cases that show incredibly bad behavior. But I think on average, we do have to remember that, if we said PBMs just go away, then who takes over that job of formulary management, of negotiating with drug manufacturers? Because those companies are not just going to voluntarily lower their drug prices. They definitely want to get rid of PBMs, but one of the reasons a drug maker wants to get rid of a PBM is because they're so effective at getting the price down. So, we kind of are stuck with them in our current system. Do we need to throw out the entire system? Probably, but like as it is, I think we're stuck with PBMs. We just need to do a better job of like both understanding how they're compensated and being more clear about, what is a reasonable amount of compensation here for the service that's provided, because they are providing a service.
Yeah, I had one of my final questions, but I have another question after this. It was like, in your opinion, do you think PBMs are ever going to actually go away? It sounds like you're skeptical on that.
I'm skeptical on that broadly. I will say I give big kudos to some of the businesses that have tried to like remove themselves from the typical PBM model. So we've seen this. Blueberry Pharmacy in Pittsburgh is like a brick and mortar pharmacy that's been doing this for a long time, where it's like, come in cash pay. We're not going to deal with insurance and PBMs. More kind of recognizable would be Mark Cuban Cost Plus Drugs, where they're doing like a pass-through cost plus a markup, not trying to get into some of the gaming that we see with drug prices in general. But I think, there are, again, going back to the services that the PBM is providing largely to employers, right? We need some entity like that. We need that group bargaining power. So the large groups of people that they're bargaining for allows them to get better deals. So, if I'm coming in and saying, I'll give you preferred formulary placement or put your drug on the formulary against your competitor, you're going to get a really great deal if you have a large group of people that you're negotiating for. And if you have a small group, you're not going to get that same deal. So I think we're definitely too highly concentrated. It's too opaque. The companies are absolutely raking in profits and creating entities that don't seem to be actually needed to do any particular job except for extracting profit. That feels like there's room for cutting some of the fat while still having, profitable companies that are helping employers to manage the drug benefit.
So, final question then, as we wrap up our conversation. Again, thanks for joining us. We were talking off mic a little bit about the upcoming election. And so I'm going to ask this question. If we use it, we use it. If we don't, we don't. It seems like both major presidential candidates have talked about lowering drug costs. What do you think the role of PBMs could be, or the future of PBMs could be, given the next presidential election that's coming up in November?
I think there is going to continue to be a push to have PBM reform. And I think that no matter who ends up winning the election, that this is a topic that has resonated a lot with members of Congress, and we've continued to see legislation advanced in the House and the Senate. We're seeing a lot of legislation that's PBM targeted. So I think that no matter what happens with the election, there will be interest in continuing to dig in on PBM related issues. Now, one of the things there are two things that I think are going to be useful in the short term. One is real transparency, which sounds incredibly boring, but I think if you tried to create laws around the current PBM structure, I don't remember which PBM parent company executive said this, but one of them was quoted as basically saying, we'll just pay ourselves in a different way and maintain our profits. And so, recognizing that this is a completely opaque system, that it's hard to regulate when you don't know what you're dealing with, I think we have to get that transparency piece in, and that would be an important first step. This is going to sound even more boring, but there is a piece in the FTC report about NADAC, NADAC, so National Average Drug Acquisition Cost. What this is, it's a survey that gets sent out to pharmacies to capture what amount of money the pharmacy is paying to buy the prescription drug that the patient is filling. So this survey provides us really good information about, the pharmacy's buying this generic drug at $20 per bottle, right? That's helpful information to know. And if we knew the health plan is paying anywhere between $30 and $7,000 for that same bottle of pills, that sort of feels like a red flag. One of the problems with the NADAC as it's currently set up is it doesn't include a lot of groups that have become really important. Specialty pharmacies don't report. And so there is actually information in the FTC report about this measure, and there have been pieces of legislation that have gone forward that are we should actually require everyone to fill this out, including specialty pharmacies. And again, it feels like not that big of a deal. But if you thought about a situation where you knew what the pharmacy was paying for, especially for generic drugs, and you said, we're going to pay the lesser of NADAC plus a fee or the reimbursed price, that could help patients. It could help make sure pharmacies get paid well. These are kind of low-hanging fruit types of reforms that I would like to see moving forward, regardless of who ends up in the White House.
Well, fantastic. We're going to end the conversation there. Stacie, thanks again, as always, for joining us on Health Affairs this week. To you, the listener, hope you enjoyed this. Please send it to the pharmaceutical rep in your life, if you have one. And please subscribe and share this with a friend. And look forward to seeing you next week. Bye.